I know it's on. Welcome everyone to the Aging, Metabolism, and Emotions seminar. We are so excited to have Joe Zamaria join us today. He is a licensed and board certified clinical psychologist and associate clinical professor here at UCSF in the Department of Psychiatry and Behavioral Sciences. He's also the associate program director for our residency program, psychotherapy, and has served as a researcher and therapist in clinical trials on psychedelics. He is also a faculty at UC Berkeley in the new Berkeley Center for the Science of Psychedelics, where he directs the psychotherapy curriculum of the facilitator training program. He's a founding member of the American, Arab, Middle Eastern, and North African Psychological Association, a member of the Association of Black Psychologists, and serves on the advisory board of the Fireside Project. Now, the Fireside Project, many of you have heard of it, is the new nonprofit to support, it operates the psychedelic peer support line, free support to people who are in the midst of psychedelic experiences or integrating experiences. He's on the advisory board, 20 other professionals. He's published a paper on how it reduces harm. And what I am very excited, he's also won the APA Early Career Achievement Award. And we're just so lucky to have him at UCSF. One thing I especially appreciate about Joe is that he is a master integrator of both the art of psychotherapy and the science. And he is not kind of blind to rubrics of waiting to pay attention to something only after it has, years and, a decade or more of controlled clinical trial data. He is constantly looking at different sources of data, including clinical data, and has been involved in qualitative research and is especially involved in IPF. Sorry, tell me.
FS.
Yeah, will you be talking about that?
Actually, not so much today, but
internal family systems, which we are anyone in the field should be learning more about these days, in my view. Welcome, Joe.
Thank you. And so, shall I share my slideshow now?
Yeah.
Okay.
We will have time for questions from all of you on Zoom as well as in the room.
Wonderful. Okay. Is this getting broadcasted correctly?
Yeah, it looks great.
Wonderful. Okay.
It's not on the screen.
Oh, it's not on.
In here.
Does it need to be on the screen?
Yeah, probably.
Yeah.
One second. I can see it on the Zoom.
Yeah, I can see it too. It's because it's not plugged into anything.
Oh no, but it usually should show on the screen there. But you can plug it in and maybe that will work.
I mean, usually it's plugged into that. We're using this for.
Oh, Steffi, I didn't see you. Hi.
So you'll need to unshare, I think, from
Okay.
the,
Stop my share.
and then,
Someone just said that we can see the slides on Zoom.
Yeah, it's just not
Yeah.
displaying them.
Great.
Perfect.
Wonderful.
You're in business.
All right. Am I on camera? There I am. Okay, wonderful. It's wonderful to be here with you, a few of you that are here in person and the majority of you that are here on Zoom. I'm honored to introduce myself and just get to know some of y'all here and share a little bit about the work I've been doing. And so I'll dive right in. A little about me. Alyssa gave me a really kind introduction, but basically I'm on the faculty here in the Department of Psychiatry and Behavioral Sciences. I'm involved in psychiatry residency training, where I'm the associate program director for psychotherapy. I'm also on the faculty at UC Berkeley, where I'm the psychotherapy lead at the Berkeley Center for the Science of Psychedelics. I'll spend some time today talking about that center. What I hope to do today is to introduce the topic of psychedelic-assisted therapy. and describe the current state of psychedelic-assisted therapy research and its relationship to other types of psychiatric intervention, including conventional psychotherapy. I hope to discuss key logistics of psychedelic therapy, kind of paint a picture of what this process looks like. It might sound pretty peculiar if you're not familiar with what the trappings of this treatment are. So I hope to kind of paint that picture, and in particular, highlighting the role of the therapist in clinical trials with psychedelic therapy. And finally, I hope to describe, in addition to talking about the current state of legality with these treatments and the different routes that are emerging where this treatment may be available outside of a clinical trial setting, I also hope to talk about trends and standards of competency for preparing health professionals to become psychedelic-assisted therapists. That's a big part of my role at UC Berkeley, where it's a training program and we get all kinds of doctors, nurses, therapists, social workers, hospital chaplains, all kinds of folks who are training to become psychedelic therapists. A little bit more in depth just about my background. I started researching psychedelics in 2008 when I started graduate school. My dissertation, I used qualitative methodology to basically did long interviews with folks who were reporting positive and persisting after effects of psilocybin use. So this was a trend that was being identified in research of this era, was that folks who were enrolling in research were saying, 1 year out or 2 years out of being involved in a research trial, there were these persisting positive effects that they could trace to the profound effect of psilocybin. So they might say, I'm kinder to my spouse or partner, or I changed my job, or I started doing this new healthy habit, and they connected it to the experience they had with psilocybin. So I was trying to clarify some of that with my dissertation research. I came onto UCSF in 2014 as a fellow. By 2016, I was involved in a trial that was initiated by Brian Anderson. Brian's a psychiatrist at the General. He's on the faculty. At this time, he was a resident, and he launched this study looking at psilocybin-assisted group therapy to treat demoralization in long-term HIV survivors. This is an open-label pilot study. I will talk more about these studies.
When he started that, it's like 7 years ago.
What's that?
Well, I remember when he started that.
Yeah. And at the time,
it's crazy how long ago that was.
totally, time is just, once pandemic time hit, it just, all bets were off. But it was pretty remarkable that this was one of the first, maybe the first study in decades at UCSF involving active psychedelics with a patient population. So it was notable for that reason. Later, I started working at the Translational Research Psychedelic Program, the TRIPPER program, which is a lab run by Josh Woolley, who's a faculty psychiatrist based at the VA. And so I was a therapist in a sponsored study, a phase 2 study looking at psilocybin-assisted therapy for major depressive disorder. This was a randomized control trial. I was involved in the TRIPPER program with a few other studies. Some were clinical trials and some were other kinds of research, and I'll briefly talk about those. As Alyssa mentioned, I'm on the advisory board for the Fireside Project. Fireside, it's a harm reduction initiative. They offer free call and text for individuals who are having or who have had challenging experiences with psychedelics. And so what this means is, instead of calling 911 or instead of showing up to the ER, which might be, that kind of jams up the system, and somebody who's under the influence of psychedelics may not get the right kind of care in those settings, may find better care through Fireside Project. And we found, we published a paper this year, and we found that people who were using the line reported that they might have called 911 or they might have used the ER if they hadn't had somebody to talk to. So there is a case to be made that it's reducing the burden on the system. Finally, I joined UC Berkeley in 2022 and joined the Berkeley Center for the Science of Psychedelics. And so I'm direct the psychotherapy curriculum, lead psychotherapy instructor. And so I'll talk a little more about that too, but I just wanted to get some of this intro stuff out of the way. Very briefly, I would like to introduce psychedelic-assisted therapy. Maybe for some people in this meeting, it's a very familiar concept. Maybe for others, it's very unusual or you're unfamiliar. So I hope to just kind of dig in and paint a picture of what this treatment looks like. So very basically, it's using psychedelics in the context of some sort of psychotherapy intervention, and it's meant to achieve particular, psychotherapeutic or psychiatric outcomes. So how and why? How are we defining a psychedelic? We might think of the cultural trappings of psychedelics. Here you see some imagery from the countercultural movement in the 1960s, where psychedelics were very notably used as part of that movement. You think about hippies and Woodstock and civil rights movement and Vietnam War protests, and that psychedelics culturally get looped into a lot of this. And certainly psychedelic use was a big part of that world culturally. But I would like to think about it, not necessarily just divorced from that culture, but thinking about it a little more objectively about what is a psychedelic, how are they defined? So we can look at the etymology, the word psyche meaning mind, or going back farther meaning soul, delos meaning to manifest. So a psychedelic being a mind manifesting agent. More scientifically, we could say that psychedelics are a type of hallucinogen, which produce, being a little vague here, but characteristic range of perceptual, cognitive, and emotional effects. They tend to be profound serotonin 2A agonists. They produce these expansive, non-ordinary states of consciousness, which we're finding are psychotherapeutically helpful often. They can be synthesized, but they're found all over the natural world and used by cultures in essentially every continent for many thousands of years. There's a recorded human history, or in some cases, hypothesized human history of psychedelic use that goes back a long time. What you see here, there are 5 psychedelics listed, as well as a serotonin molecule in the lower left corner. The psychedelics listed here are known as the classic psychedelics, or the LSD-like psychedelics. So when people are properly talking about psychedelics, they're talking about this category of substances. There are other substances which phenomenologically seem to be able to produce some sort of psychedelic-like effects and can also be helpful in this paradigm. But chemically speaking, this is what we're talking about when we're talking about a psychedelic. So in the center top row, you will see psilocybin. This is what's found in mushrooms that contain psychedelics. And just below that, you will see LSD, which is actually derived from fungus as well, from the ergot fungus. Let's see, in the lower right corner, you will see something called mescaline. It's also a classic psychedelic. It's famously found in a type of cactus that is sacred to indigenous North Americans, known as peyote. It's also found in another type of cactus in South America called San Pedro. If you follow any of the news around psychedelics, you'll see that peyote is often excluded from measures that are trying to decriminalize or legalize psychedelics. And that is because it's very scarce, and it's very difficult to obtain. So it's people taking peyote sort of robs indigenous communities where it's a sacrament from accessing it. And these cactus take a super long time to fruit. So it's not so easy as just plant a field of peyote. San Pedro also has mescaline in it, but it doesn't have the same issues with scarcity. And then you see in the upper row, left and right, you see dimethyltryptamine and 5-methoxy-dimethyltryptamine. These are both classic psychedelics. DMT is actually it's an endogenous neurotransmitter. We're not I don't think we have a complete understanding of how or why it exists in the human brain. DMT is also what is found in a hallucinogenic brew that is made in the Amazon, known as ayahuasca. What's interesting about DMT is that it's not orally active. So if you consume a plant, many plants actually are abundant in DMT. If you consume it orally, it's not going to produce an effect because of monoamine oxidase. If you combine DMT with a monoamine oxidase inhibitor, it will allow the psychedelic to be orally available. And so what's really interesting about ayahuasca is that somehow these indigenous groups thousands of years ago figured out that if you mix one plant that has an MAOI and one plant that has DMT, it produces this sort of tea that is, if you ask the folks from those traditions, they will say the plants told them to mix these two plants together. It's also interesting because I don't think they're used super widely anymore, but some medications are MAOIs, and so that can produce adverse effects if they're mixed with psychedelics. So these are mainly what we're talking about. I will talk a little bit about the atypical psychedelics later. So I just wanted to talk a little bit about some of the treatment paradigms that go along with psychedelic-assisted therapy. So the first is that there are phases to the treatment. We're not just sort of like bringing somebody into the office and like feeding them LSD and having a therapy session and then saying, have a nice day. There's a lot of like build up before the psychedelic dosing takes place. So you can think, at least in the clinical trial settings, as there being 3 phases to the treatment. There's a preparatory phase, there's a dosing phase, there's an integration phase. The prep phase usually involves orienting the patient or participant to the study, to the arc of the study. And it involves some visits between the patient and the study therapists that don't involve psychedelics. So what this looks like commonly in the trials that I'm aware of are like there might be 3 sessions of 2 hours each. So about 6 hours of contact time. I've seen some studies have a little more, some have a little less, but that's about right. And what is happening in those sessions, there's a number of things. Of course, rapport is being built between patient and therapist, which I'll get into later is crucial for the efficacy of this treatment. A lot of education about the effects of the drug and how the patient can optimally prepare, especially like the night before and the morning of and so on. We go through some logistics too, like helping somebody orient to the room and say this is where the snacks and the tea is, and this is how you go to the bathroom. And just so that when we're doing that, when they're in an altered state of consciousness, that it's not so unusual, it's comfortable. That they've said, oh, we've done this drill before. I know that I have to you have to guide me to the bathroom because I won't be able to get there on my own. In addition, psychotherapeutically, we're taking a history. We're looking at the indication that they're coming to treatment for. What have they done to treat their depression or PTSD or what have you? How has that gone? And we help to formulate some intentions. So part of the work is, at least on the therapist's end, is like helping people to focus in on their issue and articulate a reasonable goal. So somebody might say something like, well, I've been reading all this stuff in the news about psychedelics and I think it's a magic bullet. I would love it if I could just take 1 dose of psilocybin and then my depression would go away. So that's, I can totally understand and appreciate that goal. And at the same time, that could set somebody up for failure where that's not likely to happen and then they're disappointed. And so, we can help shape their intention to help them become more curious about what it is that is keeping them stuck psychologically or psychosocially, or to express curiosity or interest in some other aspect of their psyche or their self that they may not normally have been able to access or interested in. And this may lead to improvement in depression, this relationship with self, this investigation in self. There's
Can you give a brief example of
yeah,
like what's the end product of an intention that will be facilitating the effects?
I like just like what I said, like if somebody said, I would like my depression to go away, I'd say, I don't know how likely that is after 1 session, but perhaps a useful intention could be something like, I would like to express curiosity towards what it is that is keeping me stuck. So that's very easy. Like anybody can do that as long as they're curious, as long as they're expressing that curiosity. So even if their depression still feels,
So it could still be vague. What's keeping me stuck?
yeah,
But I want to find out something about myself.
that could
It could
be,
be vague. Yeah.
it could be vague, but as long as it's like, it just reminds me of like setting goals in psychotherapy more generally too. It's just like if it's actionable and realistic, then it's likely to be helpful. The dosing phase refers to the period of time, it may be 1 session or it might be a couple of sessions spaced out by weeks or maybe months, where the psychedelic drug is administered. And these are usually, depending on the drug and the time that the course of the drug, might take all day or might take a good chunk of the day. So it's a lot of preparation. It's almost like preparing for a procedure, intervention, surgery, something like that. It's a big deal when the patient's finally in for their dosing session. And integration refers to kind of making sense of the experience. So if we're defining that loosely, that can happen even the day of the dosing, once the drug is wearing off and somebody is talking through their experience. But certainly the next day, it's common practice that the next day, there's always an integration session for somebody to continue to talk through their experience and their potential gains. And this happens optimally for a number of weeks beyond the dosing date. Set and setting refers to the set refers to the mindset of the person going into the experience. So this would include everything about their psyche, their history, their demographics, their experiences, traumatic experiences, their relationship to their distress, and their relationship to psychedelics, their knowledge or prior use with psychedelics. All of this is informing somebody's mindset going into the experience, as well as the setting. So that means the physical setting, what is the space like, as well as the interpersonal setting, who's there. You can imagine if somebody's taking a specific dose of psilocybin in a medical setting, surrounded by therapists and nurses and health professionals, that's a different setting than, you know, an indiscriminate amount of psychedelics taken at a concert, surrounded by lots of people you don't know or something. So it's just going to change. This changes the effects of all drugs, but it's most profound with psychedelics. And somebody could have a really, so what this has implications for how we design research and how we intervene as therapists, that there are ways to optimize set and setting to kind of get the most psychotherapeutic gain out of it. Thirdly, I'll talk about psychotherapeutic orientation. So this varies widely. There are some orientations, I think especially in like the industry, kind of private sector, that really look at the therapist's role as just like guardrails for an intense psychedelic experience to make sure people remain safe and comforted and so on. And all the way on the other end of the spectrum would be that the intervention is psychotherapy, and it's somehow being catalyzed by a psychedelic. I tend to lean that way because I see the importance of therapy in the space. You know, I think there are financial interests, and this would be very convenient financially if we didn't need a lot of personnel and if it could be administered and you just give somebody 1 or 2 doses and then they're good. But it usually needs to be bracketed by a lot of psychosocial support and intervention, which, you know, it's less financially handy, but I think it makes the treatment more effective. And then different studies might look at different types of therapy. So they've used like motivational interviewing to treat addiction, motivational interviewing being like a type of psychotherapy intervention that is commonly used to help people with addictive disorders. They've used, you know, ACT, other CBTs, plenty of other types of therapies. So depending on what they're looking at and the orientation of the researchers and the clinicians, you might see the therapy orientation changes. One last thing I want to mention, and then I'll dig a little more into psychedelics, is there's different models of treatment too. So like back in the first generation of psychedelic-assisted therapy, so it would have been like the middle of the 20th century, there was something known as a psycholytic model, which is to be contrasted from a psychedelic model. Psycholytic meant giving a small to medium dose, not a microdose, but a small to medium dose of a psychedelic to facilitate kind of a regular therapy session so that it unearths more unconscious material, people are speaking more freely and more openly about themselves, and that can be used psychotherapeutically. The psychedelic model, which is mainly what we're seeing now, is give somebody a very high dose that's bracketed by this prep and integration. So the actual dosing session may look very different than the prep and integration non-drug therapy sessions. Whereas those psycholytic sessions from the days past might look kind of a little more like a therapy session. One other thing I wanted to mention about is microdosing. I don't know if people are familiar with the idea behind microdosing, but when we're using the word microdosing to describe psychedelics, we're talking about people who are taking a sub-threshold dose of some sort of psychedelic substance. They should not feel any subjective effect from that. Commonly what is used colloquially, I've understood, is like 1/10 of a threshold dose or something. And there are different protocols that people follow. It's very popular, I understand, in the Bay Area. But there's not a lot of good research. There's not a lot of good evidence yet showing that it's any better than placebo. There need to be better designed studies to look at what are really the effects of microdosing. People report who microdose that, I had a better day. I was more patient with my kids. I got one more thing done at work. I got an extra rep at the gym, whatever. They just say I feel pretty good and I'm at my best when I'm microdosing. But we don't know that yet until we look at it more closely and compare it to placebo. One last thing I want to mention about microdosing, then I want to talk a little bit about legality and then get into some of more of the work I've been doing. About microdosing, so as I will describe, the substances that I'm talking about, things like psilocybin and LSD, don't tend to have physical toxicity. There are risks involved with using them. They don't tend to be risks involving toxicity to the body. Microdosing is a little bit of a different story, and it has to do with serotonin agonism. With psychedelics, we are hoping that they target serotonin 2A receptors. They also target serotonin 2B receptors. Repeated agonism of serotonin 2B receptors can create physiological issues that we don't want, like thickening of heart valve tissue. So if you're taking a psychedelic once a month, a high dose of a psychedelic once a month, that's probably not going to create that sort of problem. But if people are microdosing frequently, we will see frequent activation of serotonin 2B receptor sites, which can create these kind of physiological problems. So people who are interested in microdosing have developed different protocols where people take a day on and 2 days off, or there's other ways of doing it. And then also you take breaks, like people do it for a couple months and they stop for a month or something like that. Okay, so I just wanted to talk a little bit about who's there in the room with the patients in these sort of studies. In doing so, I have to describe different routes to legality, different ways that psychedelic therapy is going to become legal. There's the FDA approval route, which would allow federal legalization of psychedelic compounds used in a psychotherapeutic setting. And that involves a massive undertaking of different phases of research, phase 1, phase 2, phase 3, before some of these drugs are approved by the FDA. The FDA suggests that the people sitting in the room at one point should be doctorally trained mental health clinicians only, or clinicians only. So it'd be like an MD and a PhD or something like that. It has since been relaxed where they are also allowing people who have master's degrees in a health or mental health related field to be present, which I think makes great sense. There's nurses, there's psychotherapists, there's other sorts of people that don't happen to have a doctoral degree who may be masterful in sitting with folks. There are other routes to legalization, such as decriminalizing on the state or municipal level. So you might hear things like, oh, psychedelics are decriminalized in San Francisco or Oakland or Santa Cruz or Ann Arbor, Michigan. Actually, and that's a misnomer. They're not decriminalized. People can still be prosecuted for possession of those substances, but they're deprioritized by law enforcement agencies. So if they see somebody holding a psilocybin mushroom or something, they probably won't do anything about it. At the state level, for example, Oregon is a kind of leading the charge with legalization at a state level, where there is a psilocybin-assisted therapy is legal. You can apply through the state, the Oregon Health Authority, to get a psilocybin facilitator's license. And they require that you've had the proper training to do that work, but it doesn't require a degree. I think you could have a bachelor's degree. You may not even need a bachelor's degree, but you have to have completed some sort of program that demonstrates you're competent to do this work. Our program at UC Berkeley, we have reciprocity with Oregon. So people can come train in our program and then they can return to Oregon and apply for their facilitator's license there. So you can see, depending on what route of legality that psychedelics will take, there may be different implications about who it is that's supposed to be there in the room. I have a number of facilitators here, only because in clinical trials at UCSF and other places, it's been a common practice to have 2 therapists in the room with the patient, basically at all times. There are logistic reasons for this. If one person has to have lunch or use the bathroom or something, there's always a therapist in the room with the person. There's other reasons, there's like some other reasons for this too. And what was, the way it had been done in the past was that there was always a male-female dyad of therapists. So this had, that fact came out of a few, there's a few reasons why that's the case. The first is a really archaic reason, I think from the first generation of psychedelic-assisted therapy, where somebody supposed, oh, if you have to project issues onto a person who is a female, they'll be available to you. If you have issues to project, dad issues or whatever, to project onto a male, there will be a male therapist there as well. I think there are also some safety issues where, you know, perhaps a cisgender woman may feel more comfortable knowing that there is another cisgender woman in the room rather than two male therapists. There's, you know, so there's kind of safety issues such as that, or comfort issues. It's been kind of phased out though for a number of reasons. I know that studies I've been involved in, we've definitely had two like cisgender female therapists with a person who they may have been male or female. It goes just fine usually to have, you know, therapists of the same gender. I think it's also, you know, it takes this sort of binary look at gender identity and expression and stuff. And it's like, there's, you know, we could divvy it up by so many other ways than just through the gender binary. So, you know, we usually try to match, and in clinical trials, they try to help somebody connect with therapists that they feel comfortable with. And sometimes it may just be out of convenience that the therapist available or the therapist's available. Oh, I just wanted to talk a little bit about risks and limitations of this work. I think one of the main risks right now is the hype associated with the work. Probably y'all who are watching have also caught some popular press about psychedelic therapy. And it's on a level, it's great because there was a huge, like, you know, prohibition and you know, around psychedelics for so long. But I think what this does is it creates this. It's happened in psychiatry before, but like where people believe this is some sort of magic bullet that's going to fix all their issues. I don't think that's true. People sign up for studies, and they're finding that you know, most people are finding it very helpful to participate in studies, but some people are saying that I was disappointed, it didn't give me what I needed, and that disappointment is you know, furthered by the sort of the hype that exists culturally. Also, people get a placebo in our studies. They're very disappointed too, and then the hype, the feeling like this was the thing that was going to save my life, and now I don't get it. It can kind of exacerbate the negative effects of that they were randomized into the control group, placebo group.
Speaking of placebo, what would be a good placebo in those studies?
That's another issue I was going to talk about. Is one of the limitations is with research design.
Yeah.
There's not a really a good blinding agent you can use that is going to subjectively somehow produce the effects of psychedelics and then also but not be therapeutic. So what has been historically used, they will, in some studies they've used like a low dose of methylphenidate, which is, you know, Ritalin, a stimulant, or they'll use niacin, which is a B vitamin, which produces some kind of physiologic flushing if you take it in the right dose. So people are like, oh, something's happening. Maybe I'm tripping. But that's, you know, it's pretty easy to see through that. I think even in studies where they've looked at, it's been a double-blind study, but they had the therapist guess what the patient was on, they had patients guess what they were on. They mostly are correct because, and so in some studies they will use like a sub-threshold dose of like the study drug of psilocybin. So you don't really have to talk about, you might get this drug, you will be like, you're definitely going to get psilocybin, but it might be 25 milligrams or maybe 1 milligram. So there's no subjective effects to taking something like 1 milligram of psilocybin. But yeah, it's a really good question,
Yeah.
Steffi. I've read papers where people have hypothesized, you know, other drugs, whether they're kind of medication drugs used in the medical environment or otherwise, that might produce some sort of subjective effect. There's not a good answer there. And so this creates big problems with understanding the efficacy of this work, because it's very difficult to divorce expectancy from the bona fide treatment effects. I happen to think there are great bona fide treatment effects, but it creates this kind of little, you know, problem, and more than little problem in research. That's all I will talk about as far as risks and limitations. I'm looking at time. I have a lot to cover, and I realize there's about 20 minutes, and I want to leave some time for questions. So I was going to discuss atypical psychedelics. These are psychedelics different than those ones I listed. I'll just briefly go through these slides. There's a plant native to Africa called iboga. It produces a drug called ibogaine. It seems to be, it's still illegal in the United States. I believe it's legal in Canada and Mexico. There are physiological harms involved with ibogaine use, but it also seems to be uniquely effective in treating opioid use disorder. It seems like there are psychological and also physiologic reasons why. There's MDMA, which is commonly used in psychedelic-assisted therapy for PTSD. It's not really a psychedelic. It's really like an amphetamine class of drug, but it produces some vaguely psychedelic effects. But it seems to be similarly useful in the clinical setting, specifically for trauma. I could get into why. Essentially, it broadens the optimal zone of arousal. People are not shut down and hypo-aroused. They're not overstimulated and hyper-aroused. They're usually in a more, it's terrible to talk through trauma, but they're usually more able to do that under the influence of MDMA. They're a little more trusting of their therapists, a little more open and accepting of themselves completely. So that's why it's used in the for PTSD. It's also ketamine, which is it's really a surgical anesthetic, but it can produce some psychedelic-like effects. The advantage of ketamine is that it's legal. It's been used in the medical community forever. Its safety profile, it's much less safe actually than those other psychedelics, but its safety profile is very well understood. So it produces little risk when used wisely. Okay, I'll talk a little bit about the studies I've been involved in. The first was that pilot study back in, I think, 2016, involving HIV survivors. The patient population were older gay men who had survived essentially the AIDS crisis, AIDS pandemic, and in San Francisco in particular is a very notable population. And so it was meant to treat demoralization. The prep and integration sessions were group therapy. The dosing were individual sessions. So I think, Brian Anderson is really predominantly responsible for the design of the study. And I think we saw that it coalesced this community too, that was kind of fragmented and isolated from each other. Like one guy in the study said he had seen so many friends die that he never wanted to make a gay friend again. And so connecting with the other, in this case, it was guys in the study, was really, really powerful. A lot of guys stayed in touch after the study, traded phone numbers, continued to socialize. So that was my first time in a clinical setting using being involved in a psychedelic-assisted therapy. Later was involved, USONA Institute is the name of an organization which is attempting to further the FDA approval of psilocybin. They're one of two groups doing that. The other is called Compass Pathways. USONA is a nonprofit, Compass is a for-profit organization, but they're both looking at essentially psilocybin for depression. So as a lead therapist, basically met every patient in that study looking at psilocybin-assisted therapy for major depressive disorder.
Is that the one that was just published?
It was just published a couple weeks ago, and they're looking to do phase 3 research. So MDMA is probably the closest to becoming an FDA-approved substance, probably next year. They've completed 2 phase 3 trials initiated by the Multidisciplinary Association for Psychedelic Studies, a nonprofit, MAPS, a nonprofit based in Santa Cruz. And then you have these other 2 groups I mentioned, USONA and Compass, that are trying to push the envelope forward with psilocybin. Probably 2026 will be when phase 3 data is finished being collected for psilocybin. And both MDMA and psilocybin have been granted breakthrough status by the FDA. So that means some hurdles are removed from trying to produce enough information, enough data to show that these treatments are effective. And then I was involved in some other studies in the Tripper, Josh Woolley's program, the Tripper program at UCSF. In the interest of time, I won't get super into that. A few other things I do at UCSF related to psychedelics. I teach to pharmacy students and medical students about psychedelics in the treatment of racial trauma. So I'll just jump ahead a little bit to what does the treatment look like? What do we actually do? And then I'll open it up to questions and thoughts from others. So in those prep sessions, we're orienting the patient to the arc of the study. We're developing rapport, providing education about the effects of the drug, teaching skills. So it might be like a mindfulness skill or a somatic skill that is used in the session, but also in the prep and integration sessions. We're helping set intentions, which was that conversation we were having earlier. The rapport piece is really important. There was research. Robin Carhart-Harris, who's one of our faculty here, was the senior author on this paper. Roberta Murphy was the first author. Looking at the strength of the therapeutic relationship predicted essentially improvement in depression through this kind of convoluted route. The more likely somebody felt favorably about their treatment therapist, the more likely in this study, where there were 2 dosing sessions, they were more likely to have an emotional breakthrough. They were more likely to have a mystical experience, which is a kind of a marker of a high dose effective psilocybin session. And then this predicted improvement in depression. So basically, the more that people felt safe with their therapists, the more they could kind of go there and express or sort of process what they needed to process. And this predicted improvement in depression. So this speaks to the importance of the skill set of the therapist providing this work, and not just the techniques, not just the skills they're using, but their humanity, their personhood, and how they're connecting with their patients. Just like in conventional psychotherapy, where I think those relational pieces maybe, it's not that the techniques are not important, but those relational pieces are lower on the pyramid, or they're necessary and crucial and powerfully important in treatment.
A question about this. I was thinking about this question. I think it's kind of getting at it. So when the therapeutic alliance, I guess one of the things that always struck me about this work, to the degree I understand it, is kind of the long-lasting effects that it can potentially have.
Yeah.
And so I was wondering if there's a dark side to that. Like when the therapeutic alliance is poor, it's not that it doesn't work, it actually could go badly, and that can have long-lasting effects.
That's an interesting question. I think what they found in this particular study was that, I don't know that they found evidence for harm, but they certainly found less improvement in depression where the relationship was not as much there. I don't have a good answer for you, Eric, but
I was wondering, like, I just imagine, like, I guess I've thought about this system as like, it kind of like opens up kind of plasticity, right?
Right,
And it can go, and that's the whole idea of having a therapeutic system is to help make use of that kind of flexibility in a positive way. But I could, in the same way that you can have a bad trip under those without licensing programs around specific techniques to support this, like at like a policy level, I could imagine that there's a scenario in which it actually does do harm.
Totally, I think that's totally right. And I think that, Eric, you made me realize I wanted to speak to the mechanism behind the classic psychedelics. I mentioned that with MDMA, one hypothesis is that it increases that optimal zone of arousal. So if somebody's suffering from PTSD, they're, rather than being numbed out or overstimulated, they're a little more able to relatively calmly talk through their process with the therapist. With the classic psychedelics like LSD or psilocybin, like Eric mentioned, it makes the brain more plastic and interconnected. So think about like these disorders where there's like this stereotyped repetitive behavior, it could be like OCD or addiction or even depression. Somebody might just reflexively interpret events poorly or something. It helps kind of break that up. So it's like the one metaphor, I can't remember who coined it at this point, but it's like if you're at the top of a hill trying to ski and there's one groove to go down, you're just going to fall in that groove and keep going down that groove. Psychedelics, the classic psychedelics, kind of give you a fresh coat of snow. So you have a little bit more say in what direction you'd like to take. There was one study done by a group at NYU looking at smoking, Hopkins or NYU? I can't remember if it was Johns Hopkins or NYU or both. They were, oh geez, I think it actually was Johns Hopkins, looking at smoking cessation, psilocybin-assisted therapy for smoking cessation. These were people who had tried like many times to quit smoking without success. It's one of the hardest things to do, I think, is to quit smoking. And it's really interesting to hear what participants in that study were saying. They would take the high dose psilocybin and they were just like, this is gross. I don't want to do this anymore. And there was no wrestling about it. There was no, all the stuff that's involved with like quitting. And, it made it very simple. And I think some of it has to do with like how plastic their brain was and how they were unused to thinking about it or feeling about it that way. To your point though, Eric, yes, so it potentiates this sort of plasticity and interconnectedness between brain regions, which are normally more localized. And yeah, I think that could be lasting effects that could be traumatic. Like people who take psychedelics in naturalistic or recreational settings, maybe they take too much and then they're in a weird place and they don't know anybody there. I can imagine that could be traumatic and that could have long-lasting negative effects. So in the therapeutic environment, there's safeguards around that, and that the dose is controlled and the people are so relatively safe and so on. But yeah, I think there could be the possibility that it could accentuate whatever harm or whatever trouble is taking place.
So in your experience though, like seeing, patients go through this, it's usually a good experience.
Yeah. I think I would just want to think about what we mean by good experience or not good experience. Like oftentimes it's like a challenging experience and people are anxious and troubled and they're working through something difficult. There may be moments I've had people who are just like sheerly, blissfully joyful and are laughing or it's really satisfying that they're connecting with themselves in this way or working through whatever issue. There was a study done, I think, that looked at like people's report of anxiety in the session, how anxious they were, and then how efficacious, comparing that to how efficacious the treatment was. And I think regardless of how anxious people got, they still said, I wouldn't have changed anything, and I'm glad it went the way that it went. I see people popping up.
I was going to say, let's
questions.
have some, see if there's some questions. Did you want to go through any last slides? We have about 10 minutes for questions.
Yeah, I'll try to save most of that time for questions. I could go into detail about the integration phase. That's important. I just wanted to mention a couple of things. I just recently co-authored a book that will be published next year. It's a training book published by the American Psychological Association, looking at a specific psychotherapy modality of training called deliberate practice, specifically for psychedelic-assisted therapy. So it's a whole series produced by the APA. Different books focus on different modalities. There's deliberate practice for CBT, deliberate practice for EFT. There will be deliberate practice for psychedelic therapy. And then training at UC Berkeley, I just wanted to mention briefly, we have a 1-year certificate granting program that's open to health professionals. We have reciprocity with the Oregon Health Authority. You will see more programs like this bubble up over time as this work becomes more popular. I think what is unique about our program is it's a really small cohort and it's all in person. And we have a very multidisciplinary staff. So we're learning from chaplains and people who have learned about psychedelics in ceremonial settings or underground settings, as opposed to just clinical trials and contemporary academic research. So it's really gives a nice kind of braiding of different traditions and different orientations. Psychedelic therapy.
Amazing.
Thank you. Thanks.
It's so great to hear about this side of it from someone who's like leading, the early programs and now teaching this, training that I would say globally, there's just such a driving demand for this. So you're at the heartbeat of this. Thank you, Joe. So we've got some why don't you put on your video so we can say hi to you if you are part of our Zoom audience, and feel free to raise your hand.
I saw it was Aoife, then Ashley, then Philippe.
Yeah.
Hi, Joe, thank you so much. It's always a gift to be able to hear your really carefully considered perspective. And I don't want to waste all the time, but like, it is phenomenal how many different levels you're involved in, and we're all very lucky that you're in the field. I'm wondering about your work with Firesign and if there are common challenges that come up out in the community and that are sort of on the pathway to wider dissemination, or have you learned anything from that work that is helpful?
Yeah, I would think. Thanks, Aoife. Nice to see you. And I think I would like to actually ask the volunteers on the line what they're seeing commonly. I'm not working on the line, on the phone line or the text line, so I'm sure they have some stories and trends that they're seeing. The data that we looked at was surveys that callers completed, and they basically talked about how it was helpful and why it was helpful, and if it prevented ER visits or 911 calls and those sorts of things. And so we're finding that it is helpful. But to your point, Aoife, I think it's a great question. What are the types of things people are seeing? I would guess they have to do with maybe inappropriate dosing, people taking a little too much, maybe mixing with other substances, or just being unfamiliar with the effects of psychedelics and being, in spite of the fact of being physically safe, maybe not feeling psychologically safe or something. So that would be my guess.
Yeah, I'm sorry, it's such a huge question, but thank you so much.
Thanks for the question. Did we have Ashley next?
Yeah, hi. Thank you so
Hi.
much. This was wonderful. I really enjoyed this. I have a question about the mystical experience part that you were talking about. I was curious if anybody has looked at whether or not someone had a mystical experience during their dosing as predictive of the outcome. My understanding, and I went to one of Chuck Raison's talks the other day, and he was talking a little bit about how many people get a benefit, but there are some who don't. In terms of their depression levels. I understand that, this idea of a good trip and a bad trip is a whole other thing, but whether or not someone's depression actually went down afterward. And it did seem like there were some people whose depression either stayed the same or got worse. And I was just wondering if anybody looked at whether or not someone had a mystical experience as a moderator of that.
Yeah, it's a great question, Ashley. Nice to see you too. I know about your work and your work with Chuck and like with around temperature and metabolism and stuff. And that's all really cool. And I also know that Chuck, I know Chuck, so I know that he's gotten into this field more recently. I think there has been actually research that looked at that. I would have to think about the exact studies, but I think they have looked at. I don't know that every single time somebody has a mystical experience, it will necessarily lead to a beneficial therapeutic outcome. But I think that's the marker that is usually means it is likely then that we see some sort of therapeutic. And I don't know if that's a marker as a placeholder for something else that's happening. If people are having these mystical experiences, if that means the dose was right for the right type of plasticity to happen in the brain. I don't know how to interpret that, but I do think there's a relationship between the presence of mystical experience and then the psychotherapeutic outcomes that are looked at.
Yeah, because it almost seems like there's enough data now to maybe do a meta-analysis looking at that where we're combining data sets because it's getting, Anyway, thank you so much. This was really a wonderful presentation. I really enjoyed it.
Thank you.
Thank you, Ashley. Philippe?
Yeah, I'm thinking more about the, given increasing evidence about interpersonal neurobiology, I'm wondering about the two therapists, what they do and don't do during the many hours of the dosing component. For example, the meditating or compassion, maybe touch, maybe not touch, but what they're doing in their own mind that might also be influencing the person who's taking the plant medicine.
It's a great question, Philippe. So those sessions, depending on drug and dose, could be very exciting or very boring. The MDMA sessions in particular involve a lot of interaction between patients and therapists. It's a verbal pro-social drug, so there tends to be verbal pro-social activity. With a high-dose psilocybin session, a lot of that time, somebody may be in their own head and in their own space, and they're not communicating with us, and they don't need a lot from us. But we are sitting in a room with them for 6 or 8 hours. And so, one of my earlier mentors in the field had a very principled orientation around how we should be, which is that we're attuned and maybe we meditate, but we try our best to just be present. We're not on our phone texting, we're not reading, we're not doing other sorts of things. We just try to remain present, which is hard to do. Most people want to do something. And so, but at the same time, it reminds me, I'll throw a little more of an analogy on it. I have young kids and I remember holding them when they were babies and, let them fall asleep in your arms. And sometimes you're just aware of them and holding them and your attention is not going anywhere else and you're just focused. And if they cry or if they need something or they need to be adjusted or you need to move somewhere else, you do that and you're very ready to immediately do that. But you may be doing that for a long stretch of time. So the same kind of care, I think, is what we try to encourage during the dosing sessions.
Thank you, Philippe. And time for one last question from Marty Horowitz.
I don't have a question. I have a challenge for Joseph in the future, which is I think it's time to unpack what's meant by a mystical experience from the experiences that the people have and which are often recordable so that they can be re-examined. And I think it's a relationship between self, maybe an altered self, and something else, maybe a cultural memory, maybe a religious belief. But the Plains Indians were often looking for such an experience, and many didn't have it. I've read some of their records after taking mescaline, and so as a modern researcher, we can use qualitative methods in addition to the meta-analyses, which are clearly indicated in the future.
It's a good question, Marty. I think mystical experiences, they may be different culture to culture. The way that it's defined by the instruments that are used now to determine if a mystical experience has happened are based, it was like Walter Pahnke, who was a researcher at Harvard. He was a researcher and also a divinity student at Harvard. And then Bill Richards, who's a well-known psychologist based at Johns Hopkins, but was also active in that period of time. I think they and others put in a lot of work to develop the mystical experience questionnaire, which has been refined over time. And they're looking at these, I can't remember, 7 attributes or something that resemble these profound mystical experiences that people might have from historical accounts of spontaneous mystical experience. So it might be some sort of like ineffability, difficulty describing the experience, a deeply felt positive mood and satisfaction, this noetic quality that they're receiving information that is beyond language and it just feels so true. And there's a few other ways that it is defined. But yeah, Marty, I think more work could be done to look at
That's so beautiful. And one really quick last question from Quinn, one of our postdocs.
Hi, thank you. I was just curious if you can say anything about the features that differ between these therapeutic sessions and maybe the more traditional and ceremonial versions.
And sorry, I missed the one.
The difference between the clinical sessions, the trials you've been part of, and then the more ritualistic therapeutic in the cultural settings.
Yeah, I think there's profound differences. The number of people, who the people are, the drugs and dose that are used, the use of other plants to support the plant that's being administered, the religious or spiritual connotation as opposed to exclusively a mental health focused connotation. There's huge differences. Often I have found people that enjoy one of those worlds, enjoy the other of those worlds. And I have colleagues who, I have a colleague she's from South America, PhD trained psychologist, who spent many years in the jungle learning from elders about how the ancestral use of like ayahuasca and other plants and fungus. But she also has that kind of clinical acumen too. So it's I would say it's wildly different with maybe a little bit of intersection around, like, to be fair, we're standing on the shoulders of giants in that some of this stuff like set and setting and these relationship factors and things that we can define from an academic psychology perspective are implicit in the way that a lot of indigenous cultures relate to the use of these substances and creating ritual and all kinds of things like that. So it's a great question, Quinn, and I could speak a lot more about that.
You have our rapt attention. It's a great answer too. Thank you so much, everyone, for attending. His talk will be on the AME YouTube channel soon. Take care.
Thank you, everybody. Thank you.